Hi, this is Dr. Fox, licensed psychologist in the state of Texas, and in this video, I really want to talk about what it's like on the other side of the couch. What is it like when therapists work with individuals that are along the BPD spectrum? And I think that there is a lot of confusion about what therapists think, believe, and know about BPD. So in this video, I'm going to take some liberties and I'm going to talk about sort of my perspective in working with those who treat BPD. And by that, I mean working with therapists who treat BPD and helping them not only gain a better understanding of BPD, but also working on their perspective of BPD and adding a sense of reality to it and adding a sense of, what is genuine and that this is a good prognosis diagnosis. And I think that's really important. And I think there is a lot of confusion on both sides of the couch. So in this video, we're going to talk about the other side of the couch, the therapist perspective of BPD. And I hope that this provides some insight for you into perhaps what your therapist may think or what they may believe about BPD, and certainly about the traits that you exhibit and some of the issues and concerns that you're contending with that sort of coincide with that BPD trait or the BPD diagnosis. So like, share, and subscribe, and let's get into it. So first and foremost, I want to explain, so over the last about 12 years, I've been providing seminars to mental health providers on personality disorders. And in that, I've probably had thousands of people that have attended my seminars. And these mental health providers, some are master's level, some are psychiatrists, some are psychologists, some are psychiatric nurses, all this stuff. So it really runs the gamut. And I think that, in talking to them and talking about their cases and talking about, the issues they come up against, I think that it is important for those with BPD, for people who may watch this, to really understand not only that this is my perspective, I'm not taking it from them. This is a sort of an amalgamation of all of those things that I have acquired over the years, of questions they've asked me, of issues that they've asked me to address. And I want to incorporate that here because I think it's really important for those with BPD or BPD traits to really understand what's going on the other side of the couch, or potentially what's going on the other side of the couch. So I hope that this provides that help, and just want to give you a framework for where we're at. And I think first and foremost, I think that a lot of therapists have trouble understanding what BPD is and its manifestation. And I think it's important to realize that most mental health providers, psychiatric nurses, some psychiatrists, psychologists that are not trained in working with personality disorders in most programs. And personality disorders are not the same as non-personality disorders, right? Does that make sense? I hope that makes sense. Which is that, so personality disorders are very distinct and very different. I think that it's very different for those, let's say, who have depression or anxiety or PTSD that does not have the personality component to it. And I think that the problem is in a lot of these programs, and these programs, you only have a set amount of time and topics that you have to teach these individuals. And that's why they have practicums. That's why they have continuing education units or credits, certainly in the US, but also in the UK and also in Australia and also in different parts of the world, the Middle East, different mental health providers that I've come in contact with over the years. And it's because there's so much knowledge that there's only so much they can get in their graduate programs, right? In their medical schools, things like that. So I think that we need to realize that there is a distinction between the two. And a lot of therapists and mental health providers, they don't have that understanding of that non-personality disorder is different than personality disorder, particularly with the treatment approach. Now, what I focus on is core content and surface content. And in my seminars and in working with my students and things like that over many years, I work on making that distinction that personality disorders are different. They're like an M&M, right? And that M&M, the inside of the M&M is really what's going on, is what's driving it. It's what drives us to buy that M&M. It is initially on the outside, right? Is that depression? Is that anxiety? Is that trauma, symptoms, things like that? That's surface structure. Core structure is what's in there. Is it the almond? Is it the crispy? Is it just the chocolate, right? Is it whatever flavor, whatever's going on inside that M&M? That's the core content. That's the driving factor. And I think that's critical for them to understand. And we're not going to go real deep into that, but I just wanted to explain that many mental health providers don't really get that conceptualization. And it's not a fault of theirs, but many want to learn it. Many want to understand what is going on. Another component is there's confusion over comorbidity. And that's why I've recently written a book that was recently released, and it's called Complex Borderline Personality Disorder. And this is to illustrate the high prevalence of comorbid conditions that co-occur with BPD, which make it complex borderline personality disorder. Could be ADHD, could be psychosis, could be bipolar disorder, could be depression, right? Could be post-traumatic stress disorder, complex post-traumatic stress disorder. So it's looking at these things and it's understanding, and I think many mental health providers, they get overwhelmed with all of this information and all of these different situations and issues and manifestations of maladaptive patterns, and they become overwhelmed. And when they become overwhelmed, everyone has an individual response to that. And sometimes I think what happens is that when they get overwhelmed, they don't know what else to do. And sometimes they may kind of get lost in that sense of confusion and inability in order to help their client. And the intensity of the issue that's going on in the room, the intensity of those mental health issues, I think then sometimes they overwhelm the therapist, because therapists are people too, right? They are. Next, there's worry or concern due to rates of self-harm and suicide. And I think that that's very scary. Obviously, that's a serious issue. And I think that many individuals, they incorrectly equate any self-harm, cutting behaviors, even suicidal gestures, history of chronic, suicidality. They say, oh, well, then they must have BPD. There's many other disorders that also have self-harm associated with it, that also have high prevalence of suicidality. Now, granted, those with BPD certainly is very high. And regretfully, there is a completion rate, a pretty high completion rate of those with BPD. And I think many mental health providers become afraid of that, become very concerned about that. And, they may not know what to do with it, which is why it's so important for mental health providers to seek out consultation, to seek out other mental health providers who can help them to learn the skills to help their clients so they can manage a lot of those self-harm and suicidal tendencies, gestures, and behaviors. And next, I think that there is this issue of sort of a resistance and willingness and willfulness. And we're going to do a little deep dive into that there for sure too. And I think when we talk about resistance, now 70% of individuals with BPD tend to leave treatment early. Now, there's a lot of different factors that fall into that category. And I think that many mental health providers, sometimes they don't recognize the fluidity of treatment. It's that a lot of times, for example, that someone may have major depressive disorder. And let's say it's a moderate level of major depressive disorder. And what you do is you would identify, what are some of those thoughts and issues associated with the depression, what kind of strategies, right? What kind of thinking techniques, whatever it may be, that can help to manage that depression. Now, the individual utilizes those. They utilize them on a continual basis. They continue to push back against that depression. No, I'm simplifying it, right? But you get what I mean. And they continue to use those things, right? They realize they have control over that depression. They manage the depression. They go on and they go forward, okay? For those with BPD, what happens is that those depressive symptoms tend to be not necessarily encouraged, but brought about by the core content of abandonment, rejection, feeling invisible, feeling unimportant, whatever it may be, whatever that core content is, that drives surface structure, behavior, or symptoms of depression. Now, what this means is that not only are you teaching the skills that we talked about here, right, for depression, but you also have to work on the components of BPD. If you don't, and you just work on the depression tends not to remit. And you have to understand that those with BPD that also have comorbidity, right, or the co-occurrence of major depressive disorder, this complex BPD that I'm talking about, right, you have to deal with the BPD in order to help remit the major depressive symptoms, but also the remittance of the depressive symptoms. Individuals with BPD also have what are called depressive spirals, downward spirals. And these are common, but they're not part of a major depressive episode. They are downward spirals. So they're not as intense as severe. If that's confusing, right? That's part of the complexity that I'm talking about. That's why I think a lot of mental health providers are sort of looking like, I don't know what the heck I'm doing, what's going on. And then they see that recurrence of symptoms and it's misinterpreted as resistance. And then I think the client then feels like he or she's not helping me. They don't know what they're doing. I'm getting out of here. You're not helping me at all. And I think that every mental health provider that I've ever spoken to is genuine, wants to help their clients. They want to help their patients. They get into this field not because of the money, right, or the fame. I assure you of that they get into it because they want to help people. They want to feel efficacious in helping people. And I think that this resistance gets misinterpreted because I think we have to know what we're dealing with and what we're working with, and that goes for the client as well as the mental health provider, in order to treat it. And I think that resistance gets misinterpreted and put on the client, right? Or sometimes the client puts it on the therapist, and then both of them are like, well, heck with it, and they're out, and that adds to that 70%. So let's talk about willingness and willfulness. Now, this is a component out of DBT. We're going to talk a little bit, pull a little bit from DBT, dialectical behavioral therapy. And that is a really good, effective approach with a lot of individuals that have BPD. Not all, right? Is that DBT does not work with all individuals with borderline personality disorder, traits, or full disorder, but it works with many, and it's a really good treatment approach. But when we talk about willingness, now we want to cultivate a willing response to each situation, right? It's a willingness is doing just what is effective in each situation in an unpretentious way. It is engaging in that situation, managing that situation, putting forward a willingness to listen and use what's called a wise mind. And this is acting from your inner self and your deepest core values, right? Which most individuals that I've worked with, and I would say 99.9% of individuals with BPD, they want to get better. They want to have a greater sense of control over their emotions, their thoughts, their reactions, their beliefs, their patterns. These are hard to change. Now, since many of the folks that I work with are adults, right? So they have really sort of solidified these maladaptive patterns. They have solidified in how they respond, how they interpret and react to different situations internally and externally. And this willingness is a willingness to use that wise mind. What the wise mind is, it is that we have a rational mind and an emotional mind. And in the middle of that, right, the overlap is what's called the wise mind, right? That's the wise mind, okay? You probably couldn't see my eye in there, but, right, it's the wise mind in the middle. It's the balance of both. And what happens is when your rational mind is too intense, right, then you're overly cognitive. And you're losing that emotional component that we need to have balance. And when your rational mind is too small and your emotional mind is too intense, then you tend to be overreactive, emotionally reactive. And many people with BPD, I think, start out here, is they have those intensive emotional reactions, which creates that small emotional mind, but that wise mind then is off balance, so you can't utilize it. So what we need to do is we need to encourage and be willful of the balance of both, and utilizing both so that you have a sense of balance, you have a sense of control. And I think that mental health providers, in working with individuals that are along the BPD spectrum, need to utilize this. We need to utilize insight that encourages knowledge about self and then empower our clients to reach that state of balance. Is it easy? No, right? Is it quick? No. Is there medication to help you reach that level of balance? No. Right? And by that, I mean that medication does not treat personality. It treats surface content, anxiety, depression, psychosis, things of that nature, but not the underlying driving factors, which is often why individuals who have BPD and that complex BPD, right, that I'm talking about, that they may be on medication, that helps mitigate a lot of those surface structure issues, which helps us get to the core content. Now, when we talk about willfulness, what we're talking about is it's like sitting on your hands, right? When action is needed. It's refusing to make changes that are needed. It's this, again, it goes to this resistance, right, that we talked about. It's willfulness is the desire to be right in a situation, regardless of what is needed to get through it effectively, right? It's just that, nope, 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 right? It's that willfulness. I'm not going to do it. I don't care what you say or what you want or what you need. I don't care. Now, the other side of the couch is sometimes mental health providers are like that. Is that they get frustrated with their clients, is that they get overwhelmed with the amount of emotion in the room, with the intensity that's in the room, with the spirals that their clients have. And sometimes they get into this sense of willfulness. And in many times, a lot of my clients are like, oh, yeah, no, I'm not going to do that, right? That I don't care that this relationship is unhealthy. I don't care that, my drug and alcohol use is causing problems with my family, my friends, and my kids and all this other stuff. I'm not going to do that. And I think that as adults, people have a right to make the choices that they make. I'm sorry that if you're doing things that perhaps are negative or harmful, but, myself as a mental health provider and my colleagues that I've worked and trained and things like that, is that there's only so much that we can do. We need that individual's participation and assistance. And I think that willfulness is so difficult to contend with. And I think that it does wax and wane. It's not something that's there and it's there forever, right? But what happens is also that willfulness is this resistance to push back. It causes you to fight any suggestions that will improve the distress, that will lessen the distress, and thus make it more tolerable. And I think sometimes what happens is that therapists get overwhelmed, as I mentioned, right? That they feel ineffective in the situation and they're like, oh, I don't know what to do. This is too much, right? Because they don't understand in some cases that personality disorders, if they're in the mix, creates a greater degree of complexity, creates a greater degree of confusion, slows down the treatment process. Now you're talking about easily years of work as opposed to maybe with let's say major depressive disorder. We'll go back to that example. That now maybe you're talking, 6 months of work, depending on the severity, depending on, many, many different factors. So just generalizing. So, right, but it's about, so what is that 6 months of treatment? Whereas here with the personality disorder, we're talking about years, okay? And that willfulness, I think, adds to that confusion. But it can be on both sides of the couch, right? It can be in the clients, it can be in your mental health providers, and I think it becomes out of that confusion, becomes that resistance to do things differently, that resistance to attend group treatment, right? If you're doing DBT, it's doing group and also individual therapy. It's also the willingness to attend, sessions on a regular basis, even when you're feeling good. It is important to attend sessions when you feel good, too. Not only when you feel in distress, right? Is it also when you feel good? Because those are times to really enhance and build those strategies and really go back and recognize the power that individuals have, the power of choice, the power of doing things differently. That's when we can focus on those things. And I think one of the critical components that I think maybe gets lost is this importance of alignment, is that you have to align with your therapist, right? You have to align with your therapist against the BPD. And I think sometimes what happens is that it becomes very much an us and them kind of thing, right? Is that there's the therapist against the client and their BPD. So then what happens is that you have someone, right, the therapist, who's trying to create change in the individual. But remember, we have resistance, we have willfulness, we have sometimes poor conceptualization of the symptom complexity of an individual with BPD or with personality disorders and surface or other types of issues, right? Depression, anxiety, trauma, whatever it may be. But if we don't align, which is the client and therapist, against BPD, what happens is you end up getting stuck. You're like locked out of a room you desperately want to go into, right? In order to clean it up, let's say, but you're locked out and no one's going to let you in. So you're stuck. So what happens is that we have to align with our therapist, is that sometimes we got to talk about, okay, you know what? It's you and me, and we're getting a lot of pushback from this BPD, and you're going to get pushback from that BPD. So how do we align? How do we work together against it? It is the BPD. It is the maladaptive pattern. How do we work together for you to build strategy? I need your willingness to confront these issues. I need your willingness to let me in to work with you. And sometimes that includes processing the emotions and the times that they occur that are uncomfortable. I can't think of any of my clients who didn't hate me at one time or another, because that's part of that process, right? That it's learning these new strategies, these new adaptive strategies, and letting go of maladaptive strategies. That's scary. And I know that that's scary. And there's times that they're gonna feel willfulness and be like, nope, I'm not doing that. I don't care about that, and I hate you for suggesting it. Okay, well, let's talk about that. Let's work through it, right? But we align. And when we're not in alignment, I bring that up to my clients and say, I feel like we're misaligned here. Like, I want it to be you and me against BPD, not me working with or against you and BPD. Because if you are aligned with your BPD, it's really hard to change it. So it has to be you and your therapist. But therapists need to have that perspective as well, okay? That they are aligned with the client against BPD. One thing that, that I've heard from a lot of individuals with BPD, whether it's been, comments on the YouTube channel or, Instagram or wherever else, that they've said, well, my therapist just doesn't care. I've never had a therapist who's ever come to me and said, I really don't care if my clients have personality disorders or not, or what they're going through. I've never met a therapist who didn't genuinely care about their clients, who didn't genuinely care about the welfare of their clients, patients, individuals that they were treating. Never experienced that. I think, again, it goes back to what we just talked about. It goes back to them not maybe it's that they don't know how to work with it. Maybe they don't understand, how to work with the client, align with the client, willfulness, willingness, all of the issues that we just talked about. So I think that sometimes it is that sense of miscommunication, of lack of understanding, but I've never met one who's ever said that they don't care. And I think that caring and that compassion is a huge component. It really, really is. And I think another one is, I think that many mental health providers need to understand the strategies that can be utilized, not only in conceptualization of core content and surface content, but also the importance of encouraging clients to change their self-talk, change how they see themselves, the things they say to themselves. Sometimes some of my clients are so harsh to themselves that, they say these things that are just really just painful, and in some ways, and in many ways, very cruel, that they say to themselves that are often unjustified. And we have to work to change that self-talk. Now, just changing that self-talk, does that mean everything becomes roses and beautiful? No, because it has to be paired with insight. It has to be compared with behavior change. There's a lot of factors. And it's adding those adaptive strategies and removing those maladaptive strategies. If we can't remove those maladaptive strategies, the ones that are so destructive, that encourage the self-talk, that encourage, right, the self-harm, that encourage the suicidal gestures, that encourage, right, the willfulness, then it's really hard to align to do things differently. See how it all fits together? It all fits together, right? And then it's important to realize that there's no magic wand. This is really tough. One of my old clinical directors, right, is that, she told me, I wish I had a magic wand to go around and just smack all your clients in the head, but I don't, which means that you're going to have to work with them to do things differently. Right? Therapists can only do so much. There's just no magic wand. I wish I had one. I got something in my pocket. I don't know what it is, but it's poking me. But, right? So it's this pen. Now let's say this pen is this magic wand, right? And I would love it if you come on by the house and, right, bump you on the head and then everything is okay, whatever that would mean. So that means because there's no magic wand, it's going to be up to you to take these strategies and incorporate them. You may have to educate your therapist on where you are, what your perspective is, so they can help you build insight and align with them. Don't fight yourself or engage in self-attack. Easy to say, hard to do, because it's probably a really cemented maladaptive pattern, as it is for many people along the BPD spectrum, right? You want to resist the old urge, right? And doing that is tough, right? And it doesn't go away easily, right? But it will go away as you stay the course, as you continue to progress, as you continue to work and you align with your therapist. Even if you're using like a workbook or something like that, it's continuing to use that workbook, it's continuing to practice those new strategies. I think that individuals along the BPD spectrum, they need encouragement, understanding, and patience from their therapist, right? But you must also have that with yourself as well. And I think that sometimes, and whether this is right or wrong, I don't know, right? This is just how it is. I think sometimes some clients, some patients, they need to have those things, right? Encouragement, understanding, and patience that they give to their therapist as well, right? Allowed that they're going to make mistakes. They're people, right? They don't know everything. They don't have any magic wands. I wish they did. And mostly what I want you to remember is that this BPD is a treatable disorder. It is a good prognosis disorder. Is that it is not the fallacy of the 70s and 80s that this horrible, disorder and all this other stuff. It is difficult and it is challenging, but it is treatable and you can make changes for yourself to do it differently. Absolutely. And I hope that you find a therapist that you are able to work with. Maybe show this video, both of you go over it and talk about what they're comfortable with and what you guys can do to align, to work together against the pathology that encourages those maladaptive patterns. And what is your core content? What's driving that surface structure? These are the things that help you do things differently to grow beyond your BPD, and you can do it. And I wish you all the best. Please like, share, and subscribe. That would be awesome. And thank you all very much, and be well. Thank you. Bye-bye.